Okay, you can go ahead. Thank you, ma'am.
So, hello, good evening, everyone, and thank you very much for attending this session. So, today we will make it a case-based scenario, and we will make it in a way that you will try to guess the next step forward, because this is really one of the best ways to learn. And this is a real patient. Many times we have seen this in our outpatient departments. So, I'm confident that you will find today's discussion useful. So, our case today is an elderly gentleman, Mr. John, who comes to you with a complaint of vomiting for the past 2 days. And he describes the vomiting as having a particular appearance of darkish coffee. And he also reports passing black stools. And when you take further history, you find that these stools stick on the sides of the pan. And so we know that according to what we have learned, that these are called as tarry stools. And when you take a medical history for this patient, you find that he had started on NSAIDs about a little more than a week ago because of his knee pain. And what is the specific history that you would like to take in a patient with this background and age group? Is there a particular history of liver disease and or alcohol abuse? And you find that for this gentleman, there is neither. At this step, I'd like you to think a moment, or if you have a notepad and pen, just to write down in your head or on a piece of paper what you think the possible diagnosis could be before we move to the examination part, right? So I'll give you 1 second for that. Okay? Right. So now let's move to the examination. And on examining Mr. John, you find that he's pale, his demeanor is anxious, his blood pressure is on the lower side. You find it to be 90/70, and his pulse is on the higher side, so it's around 120 per minute. So when you do an abdomen examination, you find that there's a tenderness in the epigastric region. Other than that, there is no organomegaly, and the rest of the abdomen is soft. And when you do a rectal examination, you find the remnants of a blackish stool. So at this juncture, again, I'd like to ask you to take a second and think of the possible diagnosis for this patient. Okay, so before we move to the next slide. So, right? Okay, so let's move on. So, most of you would have guessed from the topic itself, what we saw from the wonderful introduction that we had, that this is most likely a case of upper gastrointestinal bleed, right? And in this case, it's possibly non-variceal. Now, we will discuss what the difference between the presentation of a variceal and a non-variceal GI bleed is later on. But at this moment, I'd like you to think of the possible differences by yourself now, so that later in the discussion, you might find it helpful. And so we find that in this particular scenario, this gentleman probably may have had a gastric or a duodenal ulcer, probably induced by his intake of non-steroidal anti-inflammatory drugs, which we know have an established association with the development of ulcers. And we also know that in the elderly age group, there is an increased proclivity to develop such ulcers. Right? So this is a point I'd like to draw your attention to, because this is often missed, especially in a busy outpatient. And if you see someone coming with a dramatic history like coffee ground vomiting. And so a lot of the times I've seen young doctors mistaking the medicine history. And so that's terribly important. So please remember to take that. So this is one of the main reasons I chose today's case. So this can make the difference between a correct diagnosis and an incorrect diagnosis, and sometimes between life and death. So what will you do especially given the presentation of this gentleman. So certainly the first few steps would include you to establish an IV access. And for some, if the patient is unstable, you find that hemodynamically is unstable. In this scenario, he wasn't, but if he was, the first thing you would do was to resuscitate with crystalloids. And if you check his saturation and you find the oxygen to be on the lower side, so of course, you would start him on oxygen. So one of the common questions that I often get from students and young doctors alike is, when do you start transfusion? Now, this is a little nuanced, the answer to this, because usually the standard answer is, as many of you might already know, that transfusion should be started if the hemoglobin is less than 7 grams per deciliter. However, many times you will find that, especially in older patients, they would have compromised cardiac function, right? And some of them would be on medications for that. So even so, if you do find that the patient you are examining has an underlying history of cardiac problem, then it is wise to start transfusion as early as possible, because such patients usually take a longer time to recover. And as you might have guessed, they also have considerably higher rates of morbidity and mortality. Right. So medication wise, what would your action steps be? So of course, in your medication history chart, you would immediately withhold NSAIDs. And what you would do next is to start him on a PPI, preferably a high dose one. And the dose is up for you to see, right? So the bolus dose and then the infusion dose, right? So these are usually quite uh, easy to remember, but it's good to have it up on a piece of paper, whether if you're working in the ICU or in your wards, because sometimes if there's a rush to stabilize the patients, sometimes it's possible to make mistakes with the dose. And if you do make a mistake, that generally leads to legal trouble later. So please do certain standard doses. It's good to have, up on the ward or the ICU board, just for your reference. So the next step, so this is when we come to the uh, GI endoscopy, right? So there is one caveat. So of course, it needs to be done, definitely. There is the caveat here is that there is a difference between the something called as the urgent GI endoscopy and what is called as early endoscopy, right? So what I'm going to give you now, these guidelines are as per the latest, the American, the European, and the Canadian, the gastroenterological societies combined. So this is the standard advice. And so their advice as of 2025 is that it is better to avoid um, emergent endoscopy in such patients with suspected non-variceal upper GI bleed. So what do I mean by emergent? So emergent would be within 6 to 12 hours. So it's emergency, right? The first 6 to 12 hours. So what is better is early endoscopy, right? So early is within the first 24 hours. So you want to try to do it within the first 24 hours of the patient's presentation, right? It is been found through trials and tests that doing the endoscopy within the first 6 to 12 hours is not necessarily linked to better patient outcomes. So in summary, so it is best to arrange the endoscopy within the first 24 hours. And of course, before doing any endoscopy, we have to ensure that the patient has been resuscitated and is sufficiently stable for you to perform the endoscopy. And I cannot emphasize this point enough, because what happens, especially in busy hospitals in India, is that The doctors generally rush into the endoscopy within the first few hours without taking enough time to stabilize and resuscitate the patient. And that leads to big problems if the patient decompensates later. And you can imagine that leads to a lot of stress and sometimes medical legal challenges. So, whatever we discuss during the course of our talk today, it will be both practical aspects of course, providing the best standard of care for the patient. Of course, it's also equally about how to protect yourself and how you can stay within the legal guidelines of medical practice. So, both aspects are equally important because there's not enough emphasis on medical legal aspects during our medical education. So that's the reason I always make it a point to include it in my talk. So the next one, of course, the among the most common bacteria causing peptic ulcers is Helicobacter pylori. I'm sure you all are well aware of that. So you, of course, during the endoscopy, you can test for that. And if it's found positive, you start the patient on the whole course of medications. And we must always remember not to forget to monitor the vitals, certainly the urine output, and when you feel it is appropriate and the patient is stable enough and you've transfused enough, repeat hemoglobin when required. So, and the last point is, I think, common sense. Of course, you would start other anticoagulant medications, of course, when you have made that assessment that the risk of rebleeding is now low. Right? Now, so as promised, this is the part that a lot of the times you know, students ask me. And so, how would you distinguish between a patient coming with a variceal bleed and a non-variceal bleed? Right? I hope I'm not running out of time. I think, do I have enough time? Can I ask Asia, is there how much time I have left for the talk? Hello? Hello? Okay, I think I've got. Hello? Okay, I'll just carry on then. So very quickly, um, right. So by history, usually the patients with a variceal bleed will come with a history of liver disease, alcohol abuse, or you might have a history of hepatitis. Right. Um, a non-variceal bleed would commonly have a presentation of, patient taking NSAIDs, or uh, or you might suspect a history suggestive of peptic ulcer. And examination-wise, in a variceal bleed, there might be jaundice, ascites, splenomegaly, so more stigmata of liver disease. And in a non-variceal bleed, they're usually more subtle, the examination. And as we saw in this patient, there was epigastric tenderness, but it was otherwise normal. In a variceal bleed, it's very dramatic in the sense that there is massive hematemesis. The patient presents with outright shock. And a non-variceal bleed, we find that the symptoms are slightly more different in the sense that it's coffee ground vomit. And labs, if you go with that, then variceal bleed will have thrombocytopenia, a deranged INR and high bilirubin. And a non-variceal bleed, actually anemia is relatively more common, and you might find normal liver functions. So a few, just to wrap up, a few frequently asked questions which I often get, so I thought I'd address them here. And that would be, so the first one is, what is the most common cause of a non-variceal upper GI bleed? So of course, peptic ulcers, NSAID use, and certainly in India, Helicobacter pylori. So we discussed when should endoscopy be performed before. So do remember the difference between emergent and early endoscopy. And sometimes students ask why to start PPI therapy even before endoscopy. And the reason is to reduce the risk of rebleeding. And also when you're introducing the scope, it improves the visualization because the clots have now stabilized to certain locations. So the major risk factors we've already discussed. When to transfuse blood, what are the clinical signs that would suggest a shock? So we know that certainly hypotension and tachycardia, both of which we saw in this patient, and of course again we saw pallor, hematemesis, and melena, which we again saw in today's patient. And the final question, how to prevent rebleeding. And please don't forget that PPI therapy should be continued even after the endoscopy therapy has been completed. And endoscopic therapy might include topical applications and applications of clips or thermal or mechanical ways to stop the bleeding. And of course, to be very careful with restarting NaCIDs in the future. So I think that is all from my side. These are the references and these are my contact details. Something. Things, you can't be right. Hello? Hello?
Yes, ma'am. Can you hear me now?
Yes, yes.
Okay. Just a minute, ma'am. Thank you very much, ma'am, for that comprehensive talk. The presentation which you shared was really very informative as well as lucid, and we're really glad to conduct a session with you on our platform, ma'am. Thank you very much.
My pleasure.